Assalamu alaikum wa rahmatullahi wa barakatuh. Ahlan wa sahlan wa marhaban bikum. Welcome to another edition of the Sulaimaan Ravat show. So yes, here in the Gauteng province, we are in the eye of the storm. Daily we're hearing about multiple deaths in every town, in every suburb. Families have been hit with multiple casualties in one family, in many instances in one home, people residing under the same roof. And there's a lot of talk about, how we got here, where to from here, how long is this going to last? And now this is the third wave. There was a second wave, there was a first. How many more waves? COVID fatigue is definitely at very high levels. People are wondering where to from here. Are we ever going to get to grips with this pandemic, with this virus? So joining us on the program, we have a leading voice when it comes to matters pertaining to COVID, and also well-known vaccinologist, Professor Shabir Madhi. We'll be talking about the current situation, and then we talk quite a bit about vaccines as well, inshallah. Professor, assalamu alaikum wa rahmatullahi wa barakatuh, and welcome once again to the program.
Wa alaikum salam, Moulana. Thank you for having me.
What we are experiencing currently, and especially in Gauteng, is it playing out as predicted, or is it worse, and if so, why?
So unfortunately, much worse than was predicted. So in Gauteng, as well as in the rest of the country, especially in the major provinces, all indications were that during the course of the first and the second wave, as many as 50 to 60% of people had already been infected with the virus. This is when we did antibody testing, which indicates whether people had been previously infected. Now, with that high percentage of people that were infected, one would have expected that the subsequent resurgence or subsequent wave would be less severe than what we experienced in the past, because that past infection should confer some level of protection against reinfection, as well as against developing illness from the virus. So most people, and perhaps myself included, was anticipating that this wave would occur around about May to June, which is pretty much what has transpired in Gauteng, but we were expecting a wave that should have been less severe than what we're experiencing, provided a few factors held true. And the first issue was whether the virus mutated further or not and became resistant to immune responses that were induced in the past, as well as secondly, what the impact of vaccination would have been. And then thirdly, probably, the behavior of citizens. So what we're facing currently in Gauteng is that the number of daily cases that are being diagnosed, and this particular wave has not as yet peaked. It's probably going to be another 1 or 2 weeks before the wave has peaked. Already what we're seeing is that the number of new cases that are being, the new number of new COVID-19 cases that are being reported is already twice as compared to what it was at the peak of the first and the second wave. So all indications are that the number of COVID-19 cases that will be documented this time around will exceed what we experienced in the first wave and second wave, and probably be equal to the sum of the first and the second wave. Now, whether that translates into much higher number of people that would have died with this particular wave, that still remains uncertain. Unfortunately, indications are that that is very likely to transpire. During the first wave in Gauteng, using the South African Medical Research Access mortality data, there's probably roughly about 11,000 people that died, and the second wave about 12,500 people. Currently, that figure is sitting just under 3,000 people, but the deaths that occur from COVID-19 usually lags behind the number of cases that are identified by at least 2 weeks. And the excess mortality data, there's some delay in terms of reporting as well. So all indications, unfortunately, are firstly that we definitely will have many, many more cases of COVID-19 in this resurgence compared with what we've seen previously. And secondly, unfortunately, the number of people that will die in this wave is likely to be similar, if not greater, to what we experienced the first 2 times around.
The question you hear many people asking at low, at ground level social interaction is that what is it the second wave seemed to hit KZN in a more heavier way this time around? It's Gauteng. Is it purely on social behavior? Or is there something else that kind of affects the trend?
So there is something else that probably is affecting the trend. And I think, so as an example, with the previous two waves, the Western Cape as an example, and to some extent KZN as well, the wave started in those provinces earlier than what occurred in Gauteng. Now, in addition to that, all indications are that the number of people, the percentage of the population that has been infected during the course of the first and the second wave in the Western Cape as well as in KZN is probably greater than the percentage of the population that were infected in Gauteng over the course of those two waves, which basically means there's probably greater amount of community immunity in those provinces than exists in Gauteng, which could be one of the reasons why firstly we're experiencing a much earlier resurgence than other provinces, especially relative to the Western Cape, KZN, and Eastern Cape. But secondly, why we're also experiencing more, a greater steep rise in terms of number of cases. The Western Cape, in particular the Cape Metro, is a good example of what I'm sort of trying to illustrate, where the metro that was most heavily affected during the course of the first wave was Kailicha. They had the highest infection rate as well as the highest mortality rate, the number of people that died per 100,000 of the population. But interestingly, in the second wave, what transpired in the Western Cape, in the Cape Metro in particular, was that the mortality rate from COVID-19 was much lower in Kailicha compared to many of the other parts of the Western Cape. And this is possibly because of them having developed a fair amount of immunity, not necessarily against infection, but at least immunity that was sufficient to protect them against developing severe disease. So I think there is this heterogeneity, these differences that are being experienced across the different provinces with this current resurgence, which are partly because of what had transpired in the earlier two waves.
Now, we know in Gauteng there's a big percentage of Indian Muslims, and there has been talk about the vulnerability of those who are of Indian origin. Can you talk us through the science there?
Okay, so there's two parts of it. The first part is whether people of Indian ancestry are at greater risk of developing severe COVID-19 and of dying of COVID-19. And certainly in the United Kingdom, as an example, they did show that people from the Indian ancestry were at higher risk of developing COVID-19 and also had poorer outcomes. Now, in South Africa, what the NICD has basically shown is that when hospitalized for COVID-19, people of Indian ancestry are at a 35% greater risk of dying of COVID-19 compared to whites. And then if you look at people of Black Africans or people of mixed ancestry colors, compared to whites, they're at about 23 to 24% greater risk of dying after being hospitalized for COVID-19. And all of this is independent of the other risk factors prevalent in the Indian community. As an example, a high prevalence of hypertension, of diabetes, of obesity. So independent of those factors, it seems that being of Indian ancestry is associated with a greater risk of dying, 35% higher than whites, as an example, when hospitalized for COVID-19. Now, compounding that is that because of the nature of our communities and the social engagements and social interactions, including many communities many households being multi-generational households, that unfortunately does lend itself to much quicker spread of the virus. If you got, especially to high-risk individuals, when you're living in those multi-generational households, which could contribute to what we have been observing. Last but not least, and something which is extremely uncomfortable for us to accept, is unfortunately what's transpired in Gauteng, and particularly the Greater Johannesburg region, during the course of the past 2 to 3 weeks, based on what we understand of the virus. It links to social activities that probably occurred towards the end of the fasting month and over the Eid period. And what we're seeing now is unfortunately a resurgence that exceeds what is being observed in other communities in Gauteng, as well as especially in Johannesburg, in the Greater Johannesburg region. And that is just simply because during that period of time, people were more likely to be engaging in indoor activities, and particularly in poorly ventilated spaces. What we know about this virus is that the biggest risk factor to get infected is gatherings in poorly ventilated indoor spaces, and more so if people are not wearing face masks. And unfortunately, it would appear that because of circumstances, that is possibly what has resulted, at least in a section of our communities.
On that point, Professor, I'm glad that you brought it up because, I think there was an article penned for a medical journal recently where similar stats were mentioned, and the example was given of the Muslim community and the tail end of Ramadan and Eid, etc. And within the community, it seems to have stirred some debate where those who argue that why is it that the Muslim community is independently keeping stats? We're not seeing something similar in the Jewish community or in the Christian community. Why are our Muslim practitioners and professionals highlighting these things in the mainstream? It could inadvertently lead to the broader citizenry starting to assume that Muslims are responsible now for the outbreak or for the resurgence in Gauteng. Surely there has been poor behavior in other communities as well. If you look at taxis, if you look at shopping malls, if you look at people dropping their guard when it comes to the work environment, etc. What would the response be to that line of argument?
Yeah, so firstly, it's not only the Muslim community that is keeping steps. And in fact, the Muslim community and those that are keeping the steps should be applauded for their efforts, because it's really that type of information that allows us to be educated in our response to the pandemic. So I don't think we should fault the Muslim community for keeping stats. In fact, I've seen similar sort of stats from the Jewish community, and they actually track not just the number of people that have died, but as well as the number of people in the Jewish community that have got COVID and that have got severe COVID. So the keeping of stats is not unique to the Muslim community. And if anything, like I said, they should be applauded for that initiative, because it's only based on that we can truly understand what is happening and how to plan for the future so that we can actually avoid these sort of circumstances from occurring. Is this about singling out the Muslim community? Certainly not. Irrespective of what happened in the last 10 days of Ramadan or the Eid period, the resurgence was always going to occur in Gauteng. That was predictable. This is something which I had already said in February, that Gauteng as a whole was going to experience a resurgence. Yes, we had it towards the end of May and June. And the reason for that was simply because government has not been able to vaccinate individuals at a speed that they should vaccinate people. So people remain unprotected. And consequently, as the weather starts cooling down, people are going to congregate indoors. And they're going to become more complacent to the use of face masks, as an example. And that is independent of religion or class or race. That is what is happening across the province. So it's not that the Muslim community has seeded this virus in Gauteng, or that had they behaved differently, that the resurgence would have been any different. But the resurgence would have been different in the Muslim community in terms of its timing and its magnitude, that some behavior has not taken place. And it's something that we need to understand. We cannot be completely agnostic to the reality on the ground. And the numbers don't lie. We don't create the article that you mentioned didn't create these deaths. These are deaths which you pointed out correctly. The number of janazah namazes that have been held, not on a weekly basis, but on a daily basis, is unprecedented, completely unprecedented. And if we're truly wanting to deny that, then I think we've got a problem in a community in terms of our social morality and our morality and responsibility to other members in our community. So certainly not an issue of singling out the Muslim community, simply not an issue of the Muslim community being unique in the collation of this sort of data. Like I said, we're actually lagging behind the Jewish community when it comes to the collation of this sort of data. Why have other communities that have been perhaps equally irresponsible in their behavior not been affected as much? Unfortunately, that's not true either. So even though the Indian community are at greater risk of ending up in hospital and critically dying from COVID after they've ended up in hospital, it's not unique to the people of Indian ancestry. And what we're seeing in our hospitals are hospitals that are overcrowded by people independent of race. And that is a consequence. Now, the other reason why the Muslim community and people of Indian ancestry have been especially more severely affected is we also need to understand that the major risk factor for developing severe COVID-19 in South Africa, other than it's not race, it's not religion. The major risk factor is your age. People above the age of 60 are more likely to die, about 15 times more likely to die than people under the age of 60. Now, sure, we have seen some people die in under the age of 60 age group, especially with this particular resurgence. But the age group demographic profile of people of Indian ancestry is very different to the age group demographic profile of Black Africans. Unfortunately, people of Indian ancestry in South Africa are much more wealthy. They're much more resourced. And they got much more greater access to healthcare compared to people of Black Africans, as an example. And consequently, they live longer. So there's a greater percentage of the Indian community that are above the age of 60. But in the context of COVID-19, that unfortunately results in the Indian community being disproportionately affected simply because of the greater number of people above the age of 60. So multiple factors at play, and it's not just about being Muslim, it's not just about what happened during Ramadan or during the Eid period. There's multiple players at play, but at the same time, the temporal association of what we experience when it comes to the number of people that have died and the temporal relationship in relation to the last 10 days of Ramadan as well as the Eid period, you can't deny that has contributed. If you see what happened last year as an example, with the first Eid, with the first wave, where complete restrictions were imposed, where our mosques were completely shut down, we didn't see this sort of event transpire. And that wasn't because people weren't getting infected, people were still getting infected, but people weren't getting infected as quickly as occurred this time round. And the only thing that distinguishes those two periods, yes, there is a slight different virus that's circulating, but the only other thing that distinguishes those two periods is unfortunately the social activities that we engaged in, which has resulted in this unfortunate situation.
Before we take our first commercial break, Prof, a quick comment from your side on the situation in schools. We know the Minister of Education has made it clear now they're moving in a particular direction, and we're going to come to a point fairly quickly where students are going to return and face-to-face learning is going to take place. The EFF, is one example, is not too happy about that. The medical argument seems to be that school-going kids, that age group, are far better geared to deal with the virus, even if they contract it. But the concern that is being raised is that they can still go back and pass it on to their elderly parents and grandparents, and that could exacerbate the situation. Is this now just a matter of practicalities that 1.5 years later the schooling system cannot be compromised any further, or is there a medical rationale behind this kind of approach towards not being as stringent when it comes to schools as we were perhaps a year or a year and a half ago?
Yeah, so I think it's a combination of the two. So from a scientific perspective, in South Africa, and we did a survey in Gauteng where we tested across different populations and age groups. Before the second wave had actually peaked, what we showed in Gauteng is that children under the age of 18, despite all of the school disruptions that took place last year, the shutting of schools and the limited number of days children were attending schools, despite that, children were equally as likely as adults to be infected with the virus. So the shutting of schools certainly doesn't stop children from being infected by the virus. The question is whether the reopening of the schools will increase the chances of children being infected with the virus. Now, that largely depends on multiple factors as well. But most importantly, it depends on behavior and the conditions in the school. And if children are wearing face masks and if there's good ventilation in the class again, and I can't underemphasize the importance of those two measures, you're not going to get sudden outbursts of cases in the school. In addition to which, as you correctly pointed out, even now, all the evidence are that children are at nominal risk of ending up in hospital or dying of COVID-19 unless they've got an underlying medical condition, a severe underlying medical condition that predisposes them similarly to adults to develop severe COVID-19. So what are we doing to children? We are not assisting. So when we think of children, we need to think beyond our own inner circle. And we need to think about literally the millions of children that are currently being denied a daily meal simply because that is what they depend on when they attend school for the nourishment for a day. we are denying children, in the early years especially, the formative years of their education. We are denying them education, and those years can never be recovered. The type of learnings of a child 5, 6, and 7 years of age, the type of learning that you experience in that age group are things that that almost molds your mind and develops how you're going to continue in the future in terms of your cognitive function. Those are years you're never going to be able to recover. Yes, disruption of schools is a major, major impact, and it's going to be something that we're going to suffer the consequences of for years to come, not just for the next, it's not just about these children missing out 6 or 12 months of schooling. So like I said, multiple factors at play. Should we be reopening schools? I've always advocated in a country such as South Africa, there are limited options for us, unless the virus is not going to go away. So we need to be clear about resurgences of COVID-19 are not going to end. Even if we vaccinate 40 million people in South Africa, because the current generation of COVID-19 vaccines don't work that well in protecting against mild infection, these type of resurgences will continue. So we need to ask ourselves, what is the best strategy that we have in place to be able to ensure that the livelihoods of families are protected and that the interest of the child is also protected at the same time. So yes, children might take the virus back home, but if there are adequate measures put into place, the chances of that being greater than what is currently occurring with the disruptions that are taking place in school is probably very low.
All right, we'll take a quick commercial break. When we come back, we continue the discussion with Professor Shabir Madhi. We will now focus on the aspect of vaccinations. Welcome back. So we are in conversation with Professor Shabir Madhi. Prior to the break, he was explaining to us about this current wave and the associated issues is what we were touching on. We now turn our focus to the aspect of vaccines. Now, Prof, we know the rollout has started and is at a very advanced stage in many of the first world countries. In South Africa, there's a lot of talk about why there has been a delay. The question I want to ask you up front is, how delayed are we actually? And what's a reasonable time frame for us to be able to then play catch up and come on to par?
So, I mean, we are extremely delayed. I think government's own targets initially was 40 million people by the end of 2021. They've now moved that goalpost and taken it out into the second quarter of 2022 before we get to 40 million. But I'm not even too worried about trying to get to the 40 million because that's going to have not too much of an impact compared to us just vaccinating roughly about 15 million people that are at high risk of developing severe COVID-19. Right now, we vaccinated about 2.1 million adults, including close on to 900,000 healthcare workers. So not many people in the general population have been vaccinated. Amongst people over the age of 60, of which I think there's roughly about 7 million in South Africa, currently it's just less than 20% of those that have been vaccinated, despite the vaccine program now running for more than a month. Government was targeting vaccinating all people over the age of 60 by the end of June, and clearly that is not going to transpire. So what is the reason for this? There's multiple issues. Certainly South Africa has been unfortunate as an example when it came to the cancellation of the Johnson & Johnson vaccine that was supposed to be rolled out, an unfortunate example. But at the same time, it's not that we're faultless in terms of poor planning and poor decision-making, which were planning and decisions that shouldn't have been taking place in 2021, but planning and decisions that should have occurred in 2020, in August, October 2020, which very much put us on a back foot as to when we will be able to access adequate quantities of vaccine and what timelines those vaccines would become available to us. So that is the one issue. The next issue is, are the vaccines that are becoming available to South Africa being efficiently used? And unfortunately, again, the short answer is no. Currently, there's 2.4 million doses of the Pfizer vaccine that had arrived in the country as of last week. Of those 2.4 million doses, it's only about 1.67 million doses that were used. So there's 700,000 doses lying in some depot rather than being in the arms of people that could be protected against severe disease. And vaccines don't save lives. lying in a depot. It only saves lives after it's injected into the arms of people. So why isn't the logistics of the deployment of these vaccines being sorted out? And that is what we need to focus on. The Western Cape government indicates that they're able to immediately scale up the number of people that they vaccinate on a daily basis, but they don't have enough vaccines. Yet there's 700,000 doses of Pfizer vaccine that's somewhere in the system that remains unaccounted for. Then there's an issue in terms of willingness to be vaccinated. So government clearly put a lot of emphasis on people registering on the EVDS, the Electronic Vaccine Data System, to wait for their appointments to come forward and then to be vaccinated. The EVDS was never going to function in South Africa. And I think this morning where the Minister of Health has now sort of agreed that the EVDS is actually not working and not ensuring that we get people vaccinated as quickly as possible is most welcome, but this is something that was predictable. What we need to do is government, rather than focusing on encouraging people to register on the EVDS, needs to put its resources in educating the public why it is important to be vaccinated as quickly as possible. And it needs to have an open door policy. We know who needs to be vaccinated urgently. Right now, it's people above the age of 60, as well as people above the age of 50 with comorbidities, as an example. They need to be vaccinated urgently. Government should open the doors of all the places where vaccination is taking place and encourage people to line up to get vaccinated as quickly as possible. There's the gatekeeping in terms of the number of people that need to be vaccinated needs to be done at the place where the vaccination is taking place. Over the weekend, I was at Chris Hani Baragwanath's hospital, one of the vaccine sites that are now vaccinating on a daily basis, 7 days a week. On Saturday, there were about 10 people that were present to be vaccinated when I passed the facility, rather than seeing queues of people line up to be vaccinated, which means that we're not getting the message through as to where people can get vaccinated and who should come forward as quickly as possible, irrespective of whether they've registered on EVDS or not. Who should come forward to be vaccinated as quickly as possible? So there's still a lot of work to be done. And unfortunately, that's the reason why South Africa is currently has one of the lowest vaccination rates in the world, and even one of the lowest vaccination rates on the African continent for those countries that have started to vaccinate. A country such as Botswana has vaccinated more than South Africa. Kenya has vaccinated a greater percentage than South Africa. In South Africa, we have vaccinated, excluding the healthcare workers, it would be less than 2% of South Africans have been vaccinated. The global average at the moment is around about 25%. For some countries, that figure is closer to 60 to 70% of the population. So a huge amount of effort needs to be made, but at the same time, it's also the responsibility of us to encourage people to come forward to be vaccinated and to actually take to task those individuals that cast aspersions on the importance of vaccinating people and saving lives from being lost due to COVID.
We know when it comes to vaccines, Prof, there's always been skeptics, and I suppose that's where the phrase was coined, anti-vaxxers. It seems now under COVID circumstances, it's gone to another level. There is a group of people who are historically not in opposition to vaccines or taking vaccines, but who are specifically skeptical about COVID vaccines. They feel that perhaps it was too rushed. They feel the initial group of people who are taking the vaccines are actually the guinea pigs. They ask questions like it ordinarily takes decades for vaccines to be developed, yet it was developed in under a year. What's the scientific answer to that?
Yes, I've been involved in vaccine research for 25, 26 years now. And certainly all of the vaccines that I've previously worked on, new vaccines have taken, and it's up to about 10 years from the time the vaccines were actually developed in a laboratory to the time when it eventually became licensed for use. 10 years, which has been the average for most vaccines. What has happened with COVID-19 vaccines is those vaccines have been developed in a period of about 10 months. Now, what is the reason for the difference? Firstly, we need to understand that the amount of resources on the part of governments, the amount of resources on the part of scientists, the amount of resources on many people's, on the parts of many other entities to ensure that we have adequate resources available to develop a vaccine as quickly as possible is something that is completely unprecedented. So we've got a huge amount of resources. All of the scientists that I know that have been working on vaccines on other diseases are pretty much pool their resources, mainly to focus on COVID-19, including in my own research unit. we very much suspended our programs for vaccine studies on all other vaccines whilst focusing on COVID-19. So a huge amount of money has been put into place to assist the scientists to work as a collective to make sure that we're able to get these vaccines authorized for use as quickly as possible. Now, in addition to that, what has also happened is that often when you do vaccine studies and to determine whether they are working well and they're safe, you do these studies in series, which basically means you do an initial small study in about 100 people, then do another study in about 2,000 people, and then do a study in about 30,000 people. And usually you have about a 1 to 2 year gap sometimes between each of those phases, which contributes to the timelines of a vaccine taking up to 10 years to be developed. With COVID-19, what happened is that all of those different phases of the study, the phase 1, phase 2, phase 3, they ended up taking place almost in parallel. And the reason for that is we don't have the luxury of waiting for 10 years for COVID-19 vaccine to be developed, because if we were to do that, we would have millions more people die of COVID-19. So we need to be rational in our thinking. It's either that you try to expedite the pathway whilst at the same time focus on the safety issues, or you wait for people to die and assume the luxury of time before you get the COVID-19 vaccine into the arms of individuals. Are these vaccines safe? What we do know is for most vaccines, including the COVID-19 vaccines, the main time when you would experience side effects of these vaccines are not years after being vaccinated, but rather in an immediate period after being vaccinated, the 2 to 3 week period after being vaccinated, and especially the initial few days after being vaccinated. This is the time period which for all vaccines are most likely to result in side effects. So with the vaccine trials that have been done, when they enroll 30 to 40,000 people, those sort of studies are large enough to identify fairly common side effects. Unfortunately, the more rare side effects, such as what we experienced with AstraZeneca vaccine, where it causes blood clots in the large vessels, and the chances of that occurring is 1 out of every 250,000 people, or 4 in a million. Those sort of side effects you're not going to be able to pick up unless you do a vaccine trial of probably closer to 2 to 3 million people, which is not practical. So yes, there's ongoing learnings about the safety of the vaccines, but the type of rare side effects that we're actually seeing completely dwarfs the number of people that die of COVID-19. So let's take the AstraZeneca vaccine as an example. If we were to vaccinate 40 million people with the AstraZeneca vaccine in South Africa, out of that 40 million, about 160 will develop this rare side effect of clot in the blood, the clots of the blood vessel. And out of that 160, about 40 will die. Now that is after having vaccinated 40 million people. Yesterday alone in South Africa, there were 140 people that died of COVID-19. So let us be rational in our thinking and in our criticism and in our risk assessment of vaccination. Are we still willing to allow people to die by promoting falsehoods about vaccines? And if we're doing so, I think you will need to account eventually, because every life that is lost by someone that has been discouraged to be vaccinated by someone else, or because of some sort of social media post, the blood of that person is on the hands of that person who is responsible for promoting those falsehoods.
Now, talking about some of the falsehoods that are there, one argument you hear coming up quite often, on family chat groups, WhatsApp, community chat groups, is that many people are dying after taking the vaccine. And then now recently, with the vaccine rollout having picked up momentum in South Africa, you're hearing the argument, but so-and-so took the vaccine and they tested positive. Or so-and-so took the vaccine, and even it was a month later when it was expected for them to have immunity, they still tested positive after taking the vaccine. What's the response to that, Professor?
Yeah, so I think there's 2 important issues. The first issue is that it's really unfortunate that we're vaccinating people in the midst of a resurgence in Gauteng and in the country. I mean, I personally know someone that received the vaccine and then 3 days later ended up in hospital with severe COVID. And unfortunately, that person passed on. That's not because the vaccine caused death. That's because by the time the person was vaccinated, they were unknowingly already infected with the virus. And those symptoms only manifested a few days later. And for these vaccines to have any sort of impact takes at least about 2 weeks before you start deriving any sort of effect of the vaccine. But even after 2 weeks, it doesn't mean that you're fully protected against the virus and against developing COVID-19 vaccines, especially not so in South Africa, where this beta variant dominates. So what we know about all of the COVID-19 vaccines is that the ability to protect against infection due to the beta variant is significantly diminished. For some vaccines, such as the AstraZeneca vaccine, the vaccine doesn't do anything in protecting against mild disease with the virus because of the beta, due to the beta variant. For the Pfizer vaccine, that vaccine only starts protecting against mild disease due to the beta variant after an individual has received 2 doses of the vaccine. But for all of these vaccines, they very likely, at least 2 weeks after a single dose, that's when they will start kicking in being able to protect individuals against severe disease. So I know another person as an example, someone in her 80s now, who received a vaccine and then 2 weeks later got infected with the virus. Alhamdulillah, that person, 80 years old, survived. And it's very likely that the reason she survived was because of some of the protection that the vaccine has actually induced, which didn't protect her from developing mild disease, but protected her from actually progressing and developing severe disease, which could have resulted in her dying. So the COVID-19 vaccines are not going to protect people in South Africa, where the beta variant dominates, against developing mild disease and mild COVID, but it will significantly reduce the risk of ending up in hospital and of dying of COVID-19. And that is especially important for those individuals above the age of 60 and those individuals with underlying medical conditions that increases the risk of developing severe COVID.
If somebody takes the vaccine, Prof, does it mean automatically if they go for a COVID test, they'll test positive, or will they only test positive if they do an antibody test?
Yeah, so there's 2 different types of tests. The one test is to test for the virus itself, and the other test is to test whether your body has mounted an immune response, either to the vaccine or the virus. So that is the antibody test. Now, we don't recommend that anyone has the antibody test because it's really difficult to interpret at an individual level. It's something that's useful for us as scientists to understand how much of the virus, how many people have been infected. But at an individual level, it's a complete waste of money for people to go forward to be tested for antibodies. Now, the other part is the testing for the virus, and that is where we're trying to identify genetic material of the virus with a different type of test that we do. And that will tell you that you're actually infected with the virus rather than that you've been previously infected with the virus. When someone receives the COVID-19 vaccine, the antigen tests, the COVID-19 vaccine won't cause the antigen test to be positive. If your antigen test is positive, this nasal swabs or the throat swabs that's taken, that's where we test for antigen. If that is positive, it indicates that you've been infected with the virus. And unfortunately, when people are being vaccinated, like I said, in the midst of a resurgence, quite a few people might actually end up being vaccinated when they're already infected with the virus, even if they're not symptomatic, and then 2 to 3 days later, they feel ill and they go and test and they turn out to be positive. That's not because the virus has infected you. The virus doesn't have that's not because the vaccine has infected you. Those vaccines don't have any live virus in it at all. But that positive antigen test is because you've been infected somehow by the virus itself.
Can you clarify for us the issue of fetuses and other such, from a Muslim perspective, haram ingredients being used in the manufacturing of vaccines?
Yeah, so there's one class of vaccines where the initial cell line was generated in fetal cells, but that dates back to decades. All other manufacturing processes does not involve fetal cell lines. It doesn't involve any sort of animal products. The DNA-based, the messenger RNA-based vaccines, as an example, is where the genetic material of the virus itself has been propagated, and that is what is now being encapsulated by some fatty substance, which is then being injected. So, there isn't anything obvious to me that would say that there's any haram ingredients in these vaccines. And I think a group such as IMA has also looked into this issue, and they've also declared that they couldn't identify anything that would be of concern when it comes to whether vaccines include some sort of haram substance.
The argument that Big Pharma big pharmaceuticals, they've engineered all of this, they've positioned themselves very strategically, and they are now going to make a killing with all of these vaccines in terms of profits. We know that big pharmaceuticals manufacture medicine, to make a profit. They're not doing it for any other purpose, really. But to what extent is profit a primary factor here when it comes to manufacturing of vaccines in general and the COVID vaccine in particular?
Yeah, so it differs by company. Certainly, a big pharma is going to be making a killing when it comes to profits with these COVID-19 vaccines, simply because of the huge demand. And that goes for any sort of industry. If there's a huge demand and a limited supply, you're going to have large profits. So that is the reality, an uncomfortable reality, but that one that we've lived with every day of our lives. It's not something new with COVID-19 vaccines. Is it morally justified? The answer is no, it's not morally justified. But to expect big pharma overnight to develop a social conscience and start producing vaccine and making it available for free, I think that would be naive. That's not how the world works. And then there are differences between the companies. So as an example, AstraZeneca, and that vaccine was produced by the University of Oxford. The partnership that AstraZeneca had with the University of Oxford was one that AstraZeneca would basically do a technology transfer of the vaccine to up to 10 different manufacturing sites, and they would make that vaccine available at minimal cost, at almost no profit during the course of the pandemic. So the AstraZeneca vaccine, as an example, costs about $2.5 to $5, in fact, $2.5 to $3 per dose. Pfizer and BioNTech and Moderna, as an example, those vaccines are costing at $20 a dose, 10 times the cost of the AstraZeneca vaccine. So it's easy to paint big pharma with a single brush, but there are differences. And I think there are differences in terms of the commitment with regard to pricing, with regard to ensuring access, especially to people in low and middle income countries. But at the end of the day, the reality remains that big pharma exists to turn over profits for the shareholders, and there's no getting away from that. Whether we are going to fuel it or not, unfortunately, we don't have much choices because we're not self-sufficient in South Africa to manufacture the vaccines, in fact, in the entire Muslim world. Of all of the Muslim countries, except for Egypt, which produces a nominal amount of some vaccine, and Senegal that produces a nominal amount of yellow fever vaccine, there's no manufacturing facilities in any of the Muslim-run countries. So we need to ask ourselves, why are we in this position? If we are wanting to make such a big noise about big pharma, why is it that other countries have not invested in science and ability of their countries to become self-sufficient? This is not an excuse for what is happening with regard to the type of control big pharma has got around COVID-19 vaccines. But those are the difficult questions we need to reflect on now so that when we face with a future pandemic, we can be better equipped to deal with it.
Another question that comes in with regards vaccines. On the one hand, you hear the argument that the only sustainable long-term solution in terms of overcoming the pandemic is via the vaccination program. Then you hear counter. People are saying, well, if you look at South Africa as an example, we're already in the third wave. So many people have got it. They've got immunity to an extent, or they've got antibodies. Sure, they can get it a second time, but then you can still get it even if you take the vaccine. And the vaccine is also vulnerable, if the virus mutates. So what's the difference between a person who's got antibodies as a result of having got the virus compared to a person who's taken the vaccine?
That's a really important question. And I think when we talk about vaccines as well as natural infection, we just need to be clear that there's two components to the immune responses, two major components. So one is the antibody. And that antibody is especially important when it comes to protecting individuals against being infected or developing mild COVID-19. The other component of the immune response is what we call T-cell responses. Now, we believe that those T-cell responses are much more important when it comes to protecting people from developing severe disease, which can happen even if the antibodies are not that functional against a particular variant. Now, it's completely correct. But people that have been previously infected with the virus, they actually develop immunity, including these T-cell responses. And that's the reason that if they're reinfected with the virus, they're less likely, in fact, the subsequent infection, even if it's due to to another variant, is likely to be less severe than what the individual experienced the first time around, because these T-cell responses, they remain relatively unaffected due to the mutations that have occurred even with a beta variant. But what you're saying is that the other big problem is that whether you've been previously infected or whether you're vaccinated, like I said, the beta variant that dominates in South Africa is relatively resistant to the antibody responses that's been induced by this vaccine. So consequently, Yes, if you have been previously infected, in fact, there probably is very little role for you to need to be vaccinated again to protect against against severe disease. You're probably going to be protected against severe disease by virtue of being previously infected. But if you get vaccinated, even with a single dose after being previously infected, then you are better off compared to a person that has just been infected without vaccinated in being protected even against mild disease. So it depends what level of protection you want at an individual level, which determines how much value you should place on vaccines. But the other big issue is that you don't know, unless you've really tested positive, you simply don't know whether you've been infected or not. And even if you do an antibody test, if it's negative, it doesn't mean that you previously have been infected or you haven't been infected, because there are problems with those antibody tests. So unless you were confirmed to have been previously infected, in which case, if you do get a single dose of the Pfizer vaccine as an example, you'll be able to top up your response that might even confer protection against mild disease. But if you haven't been previously infected, you're taking a gamble. And I don't think you should be taking a gamble with your life in terms of deciding whether or not you want to be vaccinated or not. Then lastly, the other big issue with vaccines is that they're much more predictable in the magnitude and the repertoire of the immune responses that it induces compared to individuals that are naturally infected. Individuals, as an example, with mild infection, asymptomatic infection, they have a very different type of immune response compared to individuals with severe disease. So you can't necessarily predict what the immunity is going to be after natural infection, whereas it's a bit more predictable when it comes to after having been vaccinated.
Final question, Prof. We're almost out of time. What's the differences? What are the key differences between the main vaccine products that are available on the market? You've got Johnson & Johnson, you've got Pfizer. I see just this week Emirates has announced that if you want to travel with them, you have to have a 2-jab vaccine, and Johnson & Johnson is not listed. So some may be scratching their heads and saying, you know, what's happening here? Is this going to be further chaos where some airlines are going to accept certain vaccines, some countries are going to accept only particular vaccines? How is this likely to unfold?
Yeah, I think it's just a matter of time before the Johnson & Johnson vaccine becomes a 2-dose vaccine as well. It works really well in protecting against severe disease after a single dose, especially in the immediate period after vaccination. But all indications say it doesn't work too well against mild infection based on what we're experiencing amongst healthcare workers in South Africa that did receive a single dose of the Johnson & Johnson vaccine. We're seeing many cases of breakthrough infections. But fortunately, most of it is mild, which is completely predictable based on the immune responses that was induced by that particular vaccine. So I think it's just a matter of time that a 2-dose schedule will become routine. And in fact, in the future, it might be that some individuals will need to get a booster dose, maybe 2 years later. Are all vaccines the same in terms of their ability to impact against COVID-19, and particularly due to the beta variant? And the short answer is unfortunately not. So there are 3 vaccines that are probably really that will probably perform similarly well, including against the beta variant. That is the Pfizer-BioNTech vaccine, the Moderna vaccine, as well as the Novavax vaccine. Other vaccines are going to perform less well against mild disease, but all of the vaccines are going to perform probably extremely well against severe COVID-19, even a single dose of the Johnson & Johnson vaccine. So it really depends what level of protection you're trying to get. In South Africa, as an example, if we were wanting to prevent resurgences from occurring, then what we're needing to do is make sure that we get as many people as possible vaccinated with the Johnson & Johnson vaccine, followed by the Pfizer vaccine, based on some studies that has been done with AstraZeneca and the Pfizer vaccine, or alternatively, people need to get 2 doses of the Pfizer vaccine. That sort of a combination will have a greater impact, even against mild COVID-19 due to the beta variant.
Prof, it's always fascinating and enlightening talking to you. Shukran for your time and for the education.
Jazakallah, thank you for having me.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Alaikum salam.
Well, viewers, until next week, inshallah, stay healthy, stay safe. Assalamu alaikum wa rahmatullahi wa barakatuh.